Hi there, I'm Faith Davies and I work in NYU Langone in New York.
My name's Gareth Morgan. I also work in NYU Langone in New York City. We've been to a very interesting meeting today here at the IMS meeting in Rio de Janeiro. It's a fascinating new look and summation of data about how to address high-risk multiple myeloma. And I thought the discussions were fascinating, and Faith here has been really key in developing the new definitions of this disease.
Yeah, so we've had a number of meetings of world experts over the last couple of years, and we launched today the new IMS, IMWG definition of high risk. And so that has four key features. The first one is deletion of 17p. The second one is either a biallelic deletion of 1p or an amplification of 1q with a deletion of 1p. The third one is a translocation, such as a 414, a 1416, or a 1420, but with a 1q and a 1p, or 1p and or a 1q. And the last one is patients with normal renal failure and a high beta-2M. So there's a few subtleties and changes from the previous criteria. And one of these is the fact that we now are encouraging people to do mutation detection. So looking for mutations of 17p, as well as trying to pick up some of the smaller deletions in 1p. And so that has a whole new set of challenges for laboratories moving forward. And I don't know if you want to talk about those things.
Yeah, first of all, I'd like to say that this is a really important change. And although you may not think it's important as a patient, I think it's very important for patients to understand this, because there's a group of people out there that have been told they have high-risk disease who clearly don't have high-risk disease based on the old definitions. And so really look at your own results, work out exactly what they mean for you, seek an opinion to help interpret it, talk to the people at HealthTree, they understand these things. So I think that's really going to be good news for a lot of people who's worried that their disease is going to run out of control and not respond. But we know that with new good treatments, the people with some of the old factors are doing perfectly well and getting long, durable remission. So important point number one. And then talking about the future, we have to have better ways of detecting these abnormalities in the clinic. We used to use FISH, as Faith pointed out, but what we need to do going forward is to use these new whole genome technologies and take advantage of AI, high throughput processing of data to rip out the important prognostic variables. Then we can add new things in, such as ApoBex signatures, different mutational groups. All of these things are going to transform the future, and we'll start to see a new generation of abnormalities that predict response to these newer treatments like CAR-Ts and bispecifics.
And it was really exciting because after talking about the definition of high risk, we were fortunate to hear a number of talks that people were giving about how high-risk patients are now responding to treatment and the importance of treating these patients very carefully and monitoring them very closely. And that the patients who are having poor drugs in particular, but also who are what we call maintaining the pressure on the clone, which is trying not to have too many breaks in treatment so that any stray cells start to grow, and how important that was, and how this had resulted in some very impressive increases in the kind of response rates and survivals for patients with fibers.
So what we see for the future is a diagnostic test up front, new treatment, probably 4 drug regimens, plus or minus a T-cell engaging therapy, assessment of your response, get 100% of people to no detectable disease, and then monitor their disease over time And if you see evidence of the disease coming back, starting treatment long before they get clinical signs or symptoms of disease. So functionally, people are cured, and functionally, they live a normal and full duration of life.